All right, party people, we are back at it with another one. Let's get it. Now, before we jump into the question itself, let's just kind of straighten out the difference between clotting factor issues as opposed to platelet issues. You need to know this like the back of your hand. So let's get it. For starters, platelet issues typically cause minor cutaneous findings. I want you thinking easy bruising, petechia, epistaxis. When I say epistaxis, I'm talking about nosebleeds. As opposed to clotting factor issues. Here, we're going to have menorrhagia. Think heavy menstrual bleeding or excessive bleeding after dental procedures. So if a kid gets his tooth extracted and then continues to bleed excessively, this is what we're thinking about. Another perfect example is hemarthrosis. In this case, we're talking about bleeding into the joints. Now, popping back over to the question. So if I was to give you a 15-year-old female with increased menstrual bleeding, as well as bruising, as well as frequent nosebleeds, and a hemoglobin of 9, hematocrit of 30, platelets 300,000, bleeding time of 10 minutes, PT time of 14 seconds, PTT of 36 seconds, as well as normal platelet studies. And of the options listed below, which one would you pick? 3, 2, 1, boom. Von Wille. Let's get it. Now, looking at this case, we're going to see that the hemoglobin is low at 9. Normal in menstruating women is 12 to 17.5. And in non-menstruating women or men is 13 to 17.5. Now, hematocrit tends to be roughly 3 times the hemoglobin value. So for menstruating women, that's about 42% plus or minus 5. Or for men / non-menstruating women, that's 47 plus minus 5. Now, you don't have to memorize these numbers exactly. Just kind of have a feel so that when you recognize it, when you see it, so if you see a hematocrit of 30%, you know that's anemic. Or if you see it above the 50s, you know that it's polycythemia. So clearly in this patient, we have iron deficiency anemia. This is likely due to the heavy menstrual bleeding. Now, she also has bruising and epistaxis, which brings us back to our clotting versus platelet conversation that we started with. Let's run through the incorrects and see how we can eliminate those. Starting with hemophilia A. Here, we know that it's wrong because it's X-linked recessive. So her being a female, immediately you can rule it out. Unless the question makes a specific point about talking about skewed X inactivation, do not pick this in a female. That is the only exception. Moreover, just for reference, hemophilia A is a factor VIII deficiency. This would cause isolated elevation in PTT. Usually what you'll see is a teen boy with hemarthrosis and elevated PTT. The treatment for this is desmopressin plus factor VIII. Moving on to ITP, immune thrombocytopenic purpura. This is incorrect because the patient has clotting factor symptoms such as menorrhagia, and ITP is only a platelet disorder. Then we're thinking epistaxis, bruising, and petechia. In the case of platelet aggregation studies being normal, as well as ITP, you have antibodies against glycoprotein 2B3A, which mediate platelet aggregation. Do not confuse aggregation with adhesion, because aggregation is platelet to platelet via glycoprotein 2B3A, while adhesion is platelet to vessel wall via glycoprotein 1b and von Willebrand factor. So typically what you'll see for ITP is school-age kid with epistaxis after viral illness. Here we'll have isolated thrombocytopenia, as well as an increased bleeding time. Now, they don't have to spell out that the kid had a virus. A lot of viral infections are asymptomatic. The other option or case that they could present you with is a woman in her 30s or 40s with random bruising. If she has an increased bleeding time, it's ITP. If it's a normal bleeding time, think domestic abuse. For ITP, the treatment is steroids, followed by IVIG, followed by splenectomy. That is the definitive treatment. Moving on to TTP, thrombotic thrombocytopenic purpura. This is caused by autoantibodies to ADAM-TS13. This is a protease that breaks down von Willebrand factor multimers. Without it, platelets clump up, causing microthrombi, and this shears RBCs. So on slide, we would see schistocytes. Schistocytes are just torn and shredded RBCs. The classic pentad that you will see with TTP is thrombocytopenia, microangiopathic hemolytic anemia, aka schistocytes, renal insufficiency, fever, as well as neurological symptoms. This patient does not fit this picture. And just remember that the mechanism for this is that you have autoantibodies directed at ADAM-TS13. Again, not relevant here. Moving on. So for vitamin K deficiency, this is incorrect because with vitamin K deficiency, you would have seen an increased PT as well as PTT time. You would have a normal bleeding in this case. Vitamin K is required for activating clotting factors 2, 7, 9, 10, as well as proteins C and S. You would normally see this in neonates, where you'd have an umbilical stump that profusely continues to bleed, or in adults on long-term broad-spectrum antibiotics. This is due to the gut flora disruption. Vitamin K is gotten from dark green leafy vegetables. Think broccoli, Brussels sprouts, cabbage, things like this. And finally, we're ending up back at that correct answer, the von Wille disease. So in this case, von Willebrand factor mediates platelet adhesion. This connects glycoprotein 1b on platelets to expose collagen on the endothelium. It has nothing to do with platelet aggregation, which would involve glycoprotein 2b/3a. So platelet aggregation studies are normal, as in this case. In von Willebrand factor disease, you always have an increased bleeding time due to defective adhesion. Also, PTT time may or may not be elevated. In about 50% of the cases, it will be, but in 50% of the cases, it won't be. Now, the reason for this is because von Willebrand factor has a secondary function of stabilizing factor VIII. Factor VIII is part of the intrinsic pathway, meaning PTT time, but this isn't always clinically significant. So, in this case, you would see clotting symptoms such as menorrhagia, bleeding after tooth extraction, and platelet symptoms such as petechia and epistaxis. This is the classic dual presentation of von Willebrand disease. Now, the inheritance pattern is autosomal dominant. Again, the treatment for this is desmopressin. The desmopressin squeezes out von Willebrand factor from the endothelial cells. The key takeaways from this question overall are von Willebrand disease gives you both clotting factor as well as platelet type problems. Bleeding time is always elevated. PTT time is elevated in about 50% of the cases, and platelet aggregation studies are normal. Do not memorize increased PTT time for von Willebrand disease. You're only going to get half the questions correct if you do. So you got to be thinking about a young woman with menorrhagia plus bruising or epistaxis. This is von Willebrand disease. A lot of the times, the patient may not even think that her bleeding is excessive. So she may even have a situation where she'll be saying, oh, I run through 4 to 5 pads every hour. And then when she asked her mom told her that it's completely normal. But since her mom also has von Willebrand disease and it went undiagnosed, she thinks it's totally normal. This is also something that you have to be aware of. All right, that is it for this one. Go crush it.